At the second session where we discussed and had brainstorming on how to curb fatty liver, and we had all our discussions. And this discussion will go on, and I think even in subsequent MASL conference also we would discuss. And with this, however, I close the session here, and I would invite Dr. Manav to take over for the next session. Dr. Manav. Next session.
The next session is on a topic which is as important as MASL, fatty liver disease, because I believe in our country, alcoholic liver disease is at least as common, if not more common than non-alcoholic fatty liver disease. To set the ball rolling, let me invite Dr. Naga Chalasani. And the moderators for the session will be Dr. Bhaskar Nandi and Dr. Harikumar Nair. The chairpersons will be Dr. Tantri, Dr. V.K. Mishra, Dr. Lakshmikant Desai, Dr. Alok Chandra, Dr. Manish Kak, and Piyush Gupta. Can I invite the chairperson and the moderator to take the seats, please?
While the moderators come up, can I, Dr. Chaudhary, congratulations on your book launch. Really incredible. I think it's around the world what we're missing is the humanism in medicine, and I think that's really what your book, and I'm looking forward to reading it on my way home this evening. Thank you. So I'll get started. I think I've already lost a minute or two. So what I was asked to talk about this morning is what are the best practices to elicit alcohol use in your patients in clinical practice? What are the lessons from West? And I was telling Dr. Padavir Raju, sitting next to me, my experience in this topic is that I drink alcohol. I have not published in this area. So that's supposed to be a joke. So I'll start with two clinical anecdotes, once again, just to highlight what seems straightforward, right? You know, somebody is drinking or not, sometimes it's just incredibly hard, at least in the West. So these are two patients that I have taken care over the course of last decade or so. First is a 36-year-old white female referred to me from my ERCP group. They've been taking care of this woman for abdominal pain, chronic calcific pancreatitis, had a number of ERCPs, stents, and so forth. Eventually, for severe pain, ended up with subtotal pancreatectomy. And at the time of this pancreatectomy, they saw liver was enlarged, a bit fibrotic, a liver biopsy showed NASH. So came to me, and I was very puzzled. This was in 2013, 2014. The dictum at the time is if you have no insulin, largely you don't have NASH. So we've done a number of things, including gastroduodenal artery and portal vein cannulation to look at insulin, glucagon, and some of the GLPs and so forth. Really puzzling, and I managed her on vitamin E. This was just soon after the PIVENS trial. And then I think I managed for 3 or 4 years or so. I was on vacation on the West Coast, and she came to OP, was seen by one of my partners for this acute presentation of jaundice, leukocytosis, and tachycardia. Dr. Orman, my partner, called me when I was in West Coast and said, Naga, I think this patient has acute alcoholic hepatitis. And initially, the patient denied consuming alcohol, but I think when she understood our condition isn't doing well, she had renal failure and so forth, readily admitted consuming lots of vodka. So about 5 to 8 years, she was able to mislead clinicians. So this is one, a bit in extreme, but can happen. Second is more recent. A 29-year-old white woman comes to the ER for liver evaluation. She is a doctorate student in physical therapy, well-educated, But has been coming to the emergency room multiple times, has been to the neurologist for MRI, EEGs and so forth for these bouts of altered mental status and seizure-like spells. And you know, interestingly, she lost some weight. Somewhere along had abdominal imaging done that showed steatosis, time to time mildly elevated liver enzymes. That's why they wanted me to see the patient. And I told the ER, why don't you just get the PET test? Normal PET is under 20. Her PET was close to 2,000. And then I saw her afterwards, and very difficult conversation. Admitted to social drinking, still she is not forthcoming. And two extreme cases where very atypical presentation. It's not like what you see, you know, people coming drunk or just the classic all cap. So it is sometimes important to be vigilant where even when it does not appear to be heavy alcohol use. Alcohol use disorder, at least in the West, is quite common. And I've seen some literature from India over the course of from 2000 to 2015, I think this is from the state of Karnataka, the alcohol use and alcohol use disorder has doubled, especially in men. It continues, at least in South India. Alcohol use in women seems to be relatively low and flat. I'd like to make this point, AUD incidence is proportional to the amount of alcohol use. Because many times patients say that I drink, but I'm not dependent on alcohol. There is a nice paper to your left. You see a table showing more alcohol you consume, more higher likely you actually have bona fide alcohol use disorder. For example, if you're drinking 4 to 6 drinks, the likelihood you have alcohol use disorder is in the order of anywhere from 7 to 17 fold, okay? Skip this. So this is an important slide. You may have seen bits and pieces of this elsewhere. Single drink means different amount of alcohol in different countries. Generally speaking, it is 10 to 12 grams of alcohol is considered a single drink. Interestingly, Britain, it is about 8 grams is what a single drink means. In Austria, it is almost 20 grams. In India, it's about 10 grams or so. To your left, what you see is what is a single drink. Not a surprise if beer is a single drink. A glass of wine, a small glass, not a big one, is a single drink because it's about 12 grams of alcohol. And then about 1.5 ounces of whiskey or hard liquor, which has 40% alcohol. Just the 2 points I would like to point out here. Now you can get beers with 12% alcohol, like Belgian Wales and ale. And the same thing with whiskey, what seemed like a 40% alcohol, which is 80 proof. You can find bourbons, especially in Midwestern United States, with 65% alcohol. And a drink is actually more than a drink. It can be 2 drinks. So keep that in mind, just paying attention to the type of beverage, the amount of alcohol, okay? So assessment of alcohol sort of comes, it's important. So it has, you want to assess alcohol use in just the general GI and liver patients you see for non-ulcer dyspepsia to irritable bowel syndrome. I think it's important to see because now we know there is no such thing as safe alcohol. I think the pendulum has swung. WHO has clearly come out to say there is no safe amount of alcohol. The National Academy of Medicine is going to come out with this report saying the same thing, and you have seen the Surgeon General in the preceding administration saying the same thing as well. So I think understanding even non-heavy alcohol consumption in your general GI practices is important. Of course, you want to understand alcohol use in patients with steatotic liver disease. What about how do patients like to be asked about alcohol consumption? This is Western data. Actually, they feel very comfortable when you probe them about alcohol use. Once again, this is a study from 35,000 Western patients, and I suspect it is not the same in different parts of the world. You know, you go to Middle East and ask them too many questions about alcohol, it may not be culturally sensitive. The same thing with parts of India. And I don't think I've seen this kind of data from from India. So in general GI practices, this is an NIAAA, this is the National Institute of Alcohol Abuse and Alcoholism. You just have to ask one question. The question could be as simple as, how often do you have a drink containing alcohol in the past year? Just, do you drink at all? And if they say yes, I think that sort of gives you an opening to ask more. The NIAAA single alcohol screening questionnaire actually asks for heavy consumption, 4 or more drinks in a single setting in women, and 5 or more in men. You don't have to do that. Just ask in a question systematically every patient you see, whether it is for irritable bowel syndrome or GERD, I think is really important. In terms of patients with SL, with steatotic liver disease, audit is what's sort of widely used. This is a very widely used, validated instrument, as 10 questions, should not take any more than 5 to 7 minutes or so. It's been translated into 54 languages, including, I think, 5 Indian languages as well. It predicts, the audit score predicts liver outcomes. So I wouldn't recommend you do this on all patients, but in patients with steatotic liver disease, of course, and alcoholic liver disease as well, alcohol-associated liver disease. Yes, 10 questions, 3 domains. Audit C is the top 3. This is about the consumption. The second is about dependence. And the third domain is harms of alcohol, both bodily harms as well as psychosocial. And this is sort of a pyramid. Majority of patients obviously at the low risk, but you can see low risk is less than 8 score, and I think there is a gender difference less than 7 for women. And if you end up doing an audit, I think you can get an idea about where the patients fall, and then also it has directions how best to intervene. In clinical trials, both any liver trial, especially in alcoholic-associated liver disease trials, you start with audit at baseline, and then you do what's called a timeline follow-back, sort of a inventory, basically asking, give a calendar and say, on this day, how much did you drink, so on and so forth. You can do retrospectively, or patients can maintain on an ongoing basis as well. This is incredibly important because you can count the total amount of alcohol that they're consuming because because you get the number of drinks and type of alcohol. Just moving on to just last few slides about the alcohol use biomarkers. A couple things, MCV, gamma GT, then you also have CDT and ethyl glucuronide, ethyl sulfate, and then the PET, okay? And MCV and gamma GT, obviously, you all know, you're brilliant clinicians. CDT, alcohol prevents the glycosylation of transferrin. Normally, it's less than 3%. If you have a heavy consumer of alcohol, it can be higher. And this is a table from Dr. Crabb's practice guideline, just gives you different thresholds. When I was in training, we were doing CDT. I think later part of my training, we switched to ETZ in urine, which you can pick up for 3 to 4 days. Now, new kid on the block is PET. There are no false positives. It is not influenced by liver or kidney disease. It actually gives you a range. Normally, it is less than 20. More than 200 is sort of heavy drinking. And 220 to 200 is sort of what the meth-ALD range. It's costly, and you need whole blood because you're looking at alcohol bound to the red cell membrane, okay? And I'm just gonna quickly go through here. The one thing though, this is a slide that I borrowed from Brian Lee. He makes a point that PET is not the gold standard, but it's actually patient self-report. I don't buy into it, and I think actually PET should be more gold standard because it's objective. But I think this is one of those things trying to be politically right, So just to summarize, and I think make it a point in your clinical practice, I suspect many of you do this, query about alcohol consumption, all patients, not just those who are suspected to have ALD. Audit C or a quasi version. You can just sort of use a modified version that comes to your mind, but I think asking somewhat systematically, especially in SLD population, is really important. And Audit-C has been translated to 4 Indian languages: Hindi, Urdu, Marathi, and Bengali. And I haven't seen any from South India. That may be an opportunity to develop. Finally, I think in your clinical practice, you can just apply these biomarkers selectively. I suggest you start eyeballing MCV and gamma GT. Then I think you can go to CDT or ETG in the urine, and I think on a case-by-case basis, PET, which is expensive, and also you have to do real time. You can't just store the sample and do it, because I think there is a decay of the PET in the red cells. That's my last slide, and I thank you for your attention.
Thank you, Professor Chalasani, for that nice presentation. We are, I think, half an hour behind the schedules. If 1 or 2 questions may be taken up. Can I have a quick comment? With the new definition of, we have segregated now MASLD, MET ALD, and ALD. And this based on the, the quantification as reported by the patient. As you rightly put it, highly subjective. Many a time you err on, when you depend on patients reporting. So do you think in future, should we be relying on a blood marker or a couple of them to segregate these 3 entities?
Thank you so much.